Ladies and gentlemen, good afternoon. I'm very honored to be here. And I'm Shang-Chin Huang from National Taiwan University Hospital Behu Branch. My topic is the impact of muscle on the natural history of chronic hepatitis B. Fatty liver disease is prevalent within chronic hepatitis B population, up to about 30%. And in recent years, new criteria for fatty liver disease have been proposed, including MASLD in 2020 and last year, MASLD criteria. They are very similar, so I will use the MASLD criteria to explain this concept. MASLD criteria has two components, hepatic steatosis and metabolic dysfunctions. And metabolic dysfunctions include A, B, C, D, E, the 5 criteria. Either one, anyone, the diagnosis of MASLD can be made. So the unsolved question is, what's the long-term impact of MASLD on the natural history of chronic hepatitis B? To answer this question, we just simplify the natural history of chronic hepatitis B into 4 stages, including viral replication and inflammation, fibrosis and cirrhosis, HCC occurrence, and finally, mortality. And MASLD has 2 components, hepatic steatosis and metabolic dysfunctions. So I will use this framework to try to answer the impact of MASLD on chronic hepatitis B. The first endpoint is HCC occurrence because it's a very important adverse outcome in patients with chronic hepatitis B. As a result, we first explore this endpoint. In this study exploring HCC risk, we included more than 10,000 untreated chronic hepatitis B patients from National Taiwan University Hospital. Among these patients, 21% had concurrent MASLD. At the baseline, patients with concurrent MASLD had a lower HBV DNA levels and a lower proportion of E antigen positivity, which means a lower viral activity at baseline. And in the long-term follow-up, patients with concurrent MASLD had a lower risk of HCC occurrence. Because MASLD have 2 criteria, including hepatic steatosis and metabolic dysfunction, so we separate these 2 criteria for further analysis. And interestingly, we found that the hepatic steatosis actually is the protective factor. However, metabolic dysfunctions are the risk factor. So metabolic dysfunction and hepatic steatosis have different effects on HCC risk in chronic hepatitis B patients. As a result, we separate these factors for the analysis. If we stratify our patient into MASLD and non-MASLD group, the metabolic burden will dose-dependently increase the risk of HCC. Even for patients with MASLD or without MASLD, metabolic burden dose-dependently increase the risk of HCC. So I will summarize the result. Hepatic steatosis is a protective factor against the HCC, but metabolic dysfunction will increase the risk. As I mentioned previously, at baseline, patients with MASLD had a lower HBV DNA level. So the next endpoint we aim to explore the impact on viral activity. We will explore the endpoint of surface antigen loss and seroconversion. In this study I just presented in early section, 4,000 patients were included. They are untreated E-negative patients, and 24% had concurrent MASLD. In the long-term follow-up, MASLD is associated with a higher probability of surface antigen loss and seroconversion. And metabolic dysfunction had additive effects on surface antigen loss. The higher metabolic burden with MASLD, the higher probability of surface antigen loss. And patients without fatty liver had the lowest probability of surface antigen loss. So I will summarize the result using this framework. Hepatic steatosis and metabolic dysfunction will suppress HBV replication, leading to a higher probability of surface antigen loss and seroconversion. And in the next study, we will focus on the the impact on fibrosis and cirrhosis. So the study endpoint will be cirrhosis and the cirrhotic complications. In this study, we included 11,500 chronic hepatitis B patients without cirrhosis at baseline from National Taiwan University Hospital. And among these patients, we found hepatic steatosis is similarly a protective effect against cirrhosis development and cirrhotic complication. So the result is consistent with the result from the HCC study. It's a protective factor for cirrhosis and HCC occurrence. Moreover, metabolic burden similarly dose-dependently increase the risk of cirrhosis. The higher metabolic burden, the higher risk of cirrhosis. Not only baseline cirrhosis, but also not only baseline metabolic dysfunction, but also new onset metabolic dysfunction will increase the risk of cirrhosis and cirrhotic complications. For example, new onset DM will increase the risk of cirrhosis and cirrhotic complication, and pre-existing DM and enrollment had the highest risk of cirrhosis and cirrhotic complication. But the new onset metabolic dysfunction will also increase the risk. So it's a summary. Hepatic steatosis, again, a protective factor for cirrhosis, but metabolic dysfunction will increase the risk of cirrhosis. And finally, the ultimate outcome is patient mortality. So in the next study, we focus on the all-cause mortality and cause-specific mortality. And in this study, we use propensity score matching for patients with and without steatotic liver disease. And patients with fatty liver or steatotic liver disease had a lower probability of all-cause mortality after propensity score matching by other confounding factors. And the protective effect is independent of metabolic dysfunctions. As can be seen here, patients without metabolic dysfunction, if this patient had steatotic liver disease, the risk will reduce. Similarly, for those with metabolic dysfunction, the risk also reduced. So we demonstrate again that steatotic liver disease and metabolic dysfunction have different effects on chronic hepatitis B patient. As for the metabolic burden, the higher risk of all-cause mortality. And not only all-cause mortality, but also cause-specific mortality, including liver-related mortality, cancer-related mortality, and cardiovascular mortality. We can see the blue line represent the patient with 3 or more metabolic dysfunctions. The high metabolic burden patient had the highest risk of all-cause specific mortality among chronic hepatitis B patients. And new onset metabolic dysfunction, not only baseline but also new onset, will increase the risk, including DM, hypertension, as well as weight gain. For patients with normal BMI at baseline, weight gain up to more than 25 BMI will increase the risk of all-cause mortality. The hazard ratio was 2.6. It's very high. So new onset metabolic dysfunction will also increase the risk of mortality. So it's a summary. Hepatic steatosis is protective against mortality, but the accompanying metabolic dysfunction will increase the risk of mortality. So it's the whole result of our current studies that hepatic steatosis may suppress viral replication, facilitate surface antigen loss, and be a favorable factor for different outcomes. However, metabolic dysfunctions will increase different risks among our patients. I will use this graphical abstract to summarize a proof finding. Hepatic steatosis and metabolic dysfunction are highly correlated, and this factor may contribute to much and increase the risk of cirrhosis and HCC. However, due to unknown mechanisms, steatosis may suppress HBV and facilitate surface antigen loss and reduce the risk of adverse outcomes. Our above findings are consistent with an excellent individual patient meta-analysis published in CMH last year. In this excellent study, the authors found that patients with fatty liver had a lower risk of HCC, cirrhosis, mortality, and a higher probability of surface antigen loss in chronic hepatitis B patients. So our results are consistent with this excellent individual patient data meta-analysis. However, there are still some conflicting results from different studies. Actually, in earlier studies, different kinds of studies have different results. We summarize in recent 5 years, there are 10 papers focused on the impact of fatty liver on HCC risk among chronic hepatitis B patients. As can be seen in the right column, the conclusion, the red ones represent risk factor, and the green one represent protective factor of fatty liver for HCC occurrence in chronic hepatitis B patients. We can see the results are conflicting. They are totally different opposite. And if we focus on the diagnosis method for fatty liver disease, we can find that in the biopsy-proven cohort, which means fatty liver is diagnosed by histology, fatty liver is a risk factor for HCC in these two studies. So it's our first possible explanation. Those who receive liver biopsy may have a higher disease severity, leading to different patient characteristics to explaining why this patient had a higher risk of HCC. And if we look at the analysis method, interestingly, we found that fatty liver tends to be a protective factor if fatty liver and metabolic dysfunction are separate in the analysis. If the authors put this factor together as one disease, such as MASLD or muscle, then the risk may be increased. But if they separate these two factors, the result tend to be protective. So it's our second speculation. Different effects of steatotic liver disease and metabolic dysfunction, as I just mentioned. And if we combine these two factors, may induce a heterogeneous metabolic burden. I will use this figure to explain this phenomenon. Muscle is composed of HS, hepatic steatosis, and metabolic burden. If a patient had high metabolic burden, and for example, DM, hypertension, obesity, more than 3 metabolic dysfunction, the final impact on HCC risk may be increased. If a patient had intermediate metabolic burden, it may be neutral. If a patient had very low or minimal metabolic dysfunction, and muscle tends to be a protective effect for HCC occurrence. It's our possible explanation for the phenomenon. And finally, I will mention a clinical strategy for patients with chronic hepatitis B and concurrent muscle, including evaluation and monitoring, lifestyle modification, and potential pharmacotherapy. Because of time issue, I will focus only on one point: aggressive correction of metabolic dysfunctions. Despite the protective effect of fatty liver on chronic hepatitis B patients, the accompanied metabolic dysfunction remains a significant risk factor for our patients. As a result, we still need to aggressively correct the metabolic dysfunction in patients with concurrent muscle. Ladies and gentlemen, here comes the conclusion. Muscle has distinct effects on chronic hepatitis B patients. Hepatic steatosis suppresses HBV, leading to lower risk of cirrhosis, HCC, and mortality. However, metabolic dysfunctions increase cirrhosis, HCC, and mortality risk. As a result, proactive and periodic screening for metabolic factor is needed for chronic hepatitis B patients. The detailed mechanisms need more study to define the possible mechanisms. This is my presentation. Thank you very much.